Welcome to our webinar titled Hereditary MDS. Thank you for joining us. My name is Lee Clark, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generous support of our corporate sponsors and the generous support of our patients, families, and caregivers for supporting the webinar today. Due to the high volume of teleconferences on the internet, it is possible you may lose your connection during the program. If you are unable to view the program online, you can call in to hear the audio portion using the call-in number in your reminder email. Today's program will be archived to our website within 2 to 3 business days. You will be notified by email when it is live and ready for viewing. Immediately following the presentation, there will be a question and answer session. Please feel free to submit your questions at any time during the presentation. To submit a question or comment, open the Q&A window in the lower part of your screen. Type in your question in the small text box window, and when you have finished typing, just hit enter. We'll do our best to get to everyone's questions today. When asking questions, I do ask that you do 2 things to help me manage the incoming questions. First, submit your entire question all at the same time. Second, please do not share private health information in your question. Our expert cannot answer any specific questions related to your personal health care. Today's specialist is Dr. Lucy Godley, who is an expert in the care and treatment of patients with diseases of the bone marrow, including leukemias, lymphomas, and multiple myeloma. She also cares for patients undergoing stem cell transplantation and patients with benign hematological conditions. Dr. Godley has a special interest in the molecular basis of bone marrow malignancies and is an active researcher in the field. In her laboratory, she studies the basis of cancer cells' abnormal patterns of DNA methylation, as well as inherited forms of bone marrow cancers. Dr. Godley's goal is to improve health through a deeper understanding and appreciation of science by integrating knowledge about fundamental networks within cancer cells and by bringing novel insights into the pathophysiology of our patients' diseases while offering them new treatment options. With all of that said, it's my pleasure to welcome Dr. Godley. Thank you for joining us today.
Well, thank you for having me. I'd really like to thank the Aplastic Anemia and Myelodysplastic Syndrome International Foundation for asking me to do this webinar. And I'm going to share my screen now. Hopefully, you can see that now. And I was asked to speak about hereditary MDS. Actually, most of what I'm going to say is also applicable to aplastic anemia. And I've put my contact information here in case that would be helpful to some of the listeners. So I always like to begin with acknowledgements. And first I begin by acknowledging my patients and their families. So this picture you see here on the left was a thank you note that the daughter of one of my patients gave to me. And she was thanking me for caring for her mom. This is supposed to be a picture of me doing a bone marrow biopsy on her mom. And it's pretty accurate, I have to say, even though she was never in the room at the time. But really, rather than my patients thanking me, I thank them because I was not working on inherited predisposition to these diseases. I was working on very basic science. But as I interacted with my patients, I started feeling like many of them were programmed to get these diseases. And I started diagnosing them. And then I diagnosed sort of too many people with inherited predisposition for this to be incredibly rare, which is what I had been taught. And so now I think I'm on a bit of a mission throughout the field to explain to doctors that inherited risk for bone marrow cancers, MDS and aplastic anemia, is really common. And I hope to share that with you today. In the lab, we have a lot of people really dedicated to this work and also other professors at the University of Chicago they've really made a difference in this field. So I think a lot of you have this idea that the doctors, if we really understood your diseases at a very detailed level, we could give you better treatment. And I believe that too. And I think the way we define someone's diseases begins with understanding the DNA they were born with, because we're all born with DNA variants, or sometimes the word mutation is used, but changes in our DNA that make us different from each other. They actually are the most identifying information about you, your DNA sequence, and that gives you risk for disease, not just for cancer, but for many, many different types of diseases. And now we know that as we age, our hematopoietic stem cell, that mother stem cell in the bone marrow that's giving rise to all of the blood cells, it's acquiring DNA changes as we go through life. And that also gives us risk, not just for the development of leukemias, MDS, aplastic anemia, but also for cardiovascular risk, like strokes and heart attacks. So people say that these inherited disorders are incredibly rare, but look at how many there are. On the left, these are genes where DNA changes confer risk for myeloid malignancies like myelodysplastic syndrome, MDS. Here in the second column, these are genes where variants give risk for lymphoid malignancies or immunodeficiencies, and some including aplastic anemia. The third column here are genes where variants give risk for either lymphoid or myeloid malignancies. And in this final column on the right, we see genes and disorders that give risk to both hematopoietic or blood cancers as well as solid tumors. And the new way that I'm trying to kind of give a visual analogy for people is that we have this riddle. You know, how much does a ton of feathers weigh? And the answer, of course, is a ton, right? It's a riddle. And the idea is each feather is very, very light. But if you have many of them, you can have something very heavy. And likewise, each one of these disorders may be relatively rare, but there are so many of them that in total, this is really common. And these feathers down here are not single genes, but take, say, bone marrow failure. Look how many genes are just contained in that one feather, right? There are so many genes, I can't even fit them on one slide or one page. And I think there's been a real underappreciation for the importance of our inherited DNA in the baseline risk that we all have for these conditions. Now, I always get asked, how often does an inherited DNA change cause one of these malignancies? So let's start with MDS. And we started this, we're trying to answer this question a couple different ways, and this is the experiment that sort of has given us the first level of results. Now, what I graph for you here is probably what a lot of you know, that MDS is a disease of the elderly. These are the ages at which MDS is diagnosed in the United States. And you can see that there's a peak here in the older age groups. So we thought, you know, why should a young person, somebody under the age of 40, be getting MDS? It is very rare, but might they have an inherited predisposition, and that's why they were diagnosed early? And so I'm an adult oncologist, so I see patients over the age of 18. So arbitrarily, we decided to look in individuals diagnosed with MDS between the ages of 18 and 40. And we also included aplastic anemia patients because, you may know, there's a bit of a spectrum of diagnosis from aplastic anemia into MDS that might be a little bit like aplastic anemia, and then into full MDS. So we took sort of the whole range of diagnosis. And our gold standard for inherited DNA is actually if we take skin cells and grow the skin cells, because the skin cells are not related to the blood system at all. So if we're able to grow skin from an individual, we have the DNA that they were born with, that they inherited from their parents. Another way that we can get the inherited DNA is by taking the cells from the bone marrow that are called mesenchymal stromal cells or stem cells. And these are, again, non-blood cells. So these are cells like the skin cells. And we learned how to grow these cells from the bone marrow aspirates of our patients. Very rarely we use saliva from people. Saliva is basically blood. It has so much contamination from blood cells. And sometimes we use like a colon biopsy or T cells, but both of these have a lot of blood in them. Of course, T cells come from blood. So we didn't use those samples very often. We really tried to use our gold standard non-blood tissue. Again, looking at the DNA that's inherited. We were able to collect samples from 121 people. You can see the breakdown here. 75 had MDS, 9 had MDS after treatment for a solid tumor, 33 patients had aplastic anemia, and 2 had acute myeloid leukemia that grew after an MDS, and 2 really looked like they had MDS. And these were collected from all over the world, because remember, this is rare to have MDS in such a young age group. And here in red, I give you the answer. In MDS patients, about 20% of them had an inherited DNA change that nobody would argue about. And in aplastic anemia patients, 15% of them had an inherited DNA change that nobody would argue about. And when I say nobody would argue about, I mean this DNA change was obviously deleterious in a gene that everybody recognizes confers risk to these diseases. If we look at a larger list of genes that hasn't really yet been associated with MDS or aplastic anemia, but is related to blood development, these numbers go even higher. 20% is 1 out of 5 individuals, right? So this is really common. And unbeknownst to me, my pediatrician colleagues were doing exactly the same experiment. They've been looking at MDS diagnosed in children from birth up until about 25 years old. And it turns out that the age at which you present with myelodysplastic syndrome or aplastic anemia basically dictates the gene that you have a mutation in. So if you present as a really, really young child, say under 5 years old, you probably have a mutation in one of the genes, SAMD9 or SAMD9L. If you present as a teenager or a very young adult, you probably have a mutation in GATA2, especially if there's monosomy 7, only 1 chromosome 7 in your MDS. And in our patients who were young adults, 18 to 40, we see DNA changes in genes that are involved in DNA repair and telomere biology. Now, there's a bias, I think. We are all taught that if you inherit a DNA change, you will get disease early. And that's what I've shown you, right? Young people with MDS, well, that's not the typical person with MDS, right? The typical person with MDS is older. But these people also have inherited predisposition, typically in a gene called DDX41. This really challenges the way doctors and other healthcare providers need to think about our patients. It means when the average person shows up with MDS, say at 72 years old, we still need to think about the inherited DNA. It's not only in the young people, it's probably across the whole age range of life. You can see we have a knowledge gap, right? We haven't done the experiment for people from 40 to 80 years old. I've written that grant a few times. It hasn't been funded yet, but I tried again recently. I hope it gets funded this time because I think it's really important to fill the gap, right? And I think what we're going to find is that there is inherited risk no matter what age you present. It's just that the age at which you present tells us something about the pathway, the biological pathway by which you're getting that disease. So if you have a inherited mutation in SAMD9 or D9L, you're going to get MDS very quickly and present very young. Whereas if you have an inherited mutation in DDX41, you're going to present much, much later. And we need to understand what is the progression, right? You're born with this DNA change. What is triggering the MDS to occur? And can we intervene and prevent that? So these are some of the key features that we think about when we see a patient or a family. And what warrants proper germline testing, or by germline, I mean inherited predisposition testing. So first of all, individuals with multiple cancers. So I mentioned before that some of our patients get MDS after treatment for a solid tumor like breast cancer or even Hodgkin lymphoma. And if someone has multiple cancers, they are reading out their predisposition to cancer for you. Now we have as many patients with what we call double cancers as these therapy-related MDS. By double cancer, I mean the person first had the blood cancer, like MDS or aplastic anemia. They're treated for that and survive long enough and then get a solid tumor. And the frequency of positive testing, I told you, for the therapy-related MDS is about 20%. It's the same for people who first have the MDS and then go on to get the solid tumor. So it doesn't matter what order you get those multiple cancers in. If you've had multiple cancers, you're showing your inherited risk. And so now if we have anyone with multiple cancers, 2 or more cancers, we really encourage them to have this inherited predisposition testing. I've shared with you our data on diagnosis of MDS at a much younger age than expected, right? MDS at 40 or younger is really, really rare. Why is that person getting disease so early? But again, the flip side of that, people who present at an average age, it doesn't mean that the inherited DNA isn't important. It just means a different set of genes is involved. And this is going to be a huge paradigm shift for our doctors and healthcare providers to think about. In many of the families I interact with, they've been asking their doctors for years and years, what's in my DNA? What's in my DNA? Look at all the cancers in my family. And doctors are saying to the patients, well, no, inherited risk to blood cancers, that's not a thing. It's super, super rare. This isn't really related to your aunt's breast cancer at 45 and this is wrong. And we really have to retrain the way our doctors are thinking. And so I've been very appreciative of the advocacy of our patients and their families because they're pushing us to recognize this. As I indicated, we take that full family history, and if our patient has MDS or aplastic anemia and there's another blood cancer within 2 generations, or young onset solid tumor, and by young, we define less than 50, then we offer the inherited testing, or some other blood abnormality. You know, if there's been severe bleeding or something in the family, then we pay attention to that. And so every time somebody has a bone marrow biopsy here at the University of Chicago, we go through and we look at their personal and family history. We talk to them again. And this is because at the time of the bone marrow biopsy, we cut into the skin, right, to do that procedure. And so it's really easy to take that skin biopsy right at that time. Patients like to just have one procedure, and that way we can do everything in that visit. We also pay attention to molecular testing that's being done on the MDS or aplastic anemia, because as we prognosticate for patients, we may find variants in genes where we really can't tell whether it's only in the MDS or was it actually inherited. So we'll go through that with you in a minute. And then, of course, many of our patients are going through allogeneic stem cell transplants as part of their therapy. And often we use family members, and we really don't want to reintroduce an inherited DNA change by using a related donor. So we pay a lot of attention at the time of transplant, and I'll share that with you. So all of these people have bone marrow biopsies, or we do a separate skin biopsy, and we grow those fibroblasts like I showed you. We make the DNA, we do this comprehensive testing, and if it's positive, we really encourage others in the family to get tested, because I believe that knowledge is power. And if we know what people are at risk for, we can give them better surveillance strategies. And if they test negative, they go into our research, and I'll show you that we can discover new disorders by talking to our patients and interacting with our patients. Now, what's the yield? Well, you can see that we test across the entire age range of life. And when you use those criteria that I show you, you won't be surprised. Testing rate is about 20%, 1 out of every 5. Now, what we say from a genetic standpoint is we aren't testing enough people. This is too high. We want a positive testing rate more about 5%. So this means maybe we should be testing everybody. We're not quite there yet, but I think we're very close to just doing inherited predisposition testing on everybody. So as I said, we do that punch skin biopsy. This is sort of what the tissue looks like, and we culture those skin fibroblasts. Now for somebody with aplastic anemia, often those skin cells won't grow. We know that from prior studies. And so often we'll take a second skin punch and we actually make DNA directly from that skin punch. Now that's not ideal because the skin punch has blood in it, but we don't want to have culture failures. So that's often what we do for those patients. Now, I told you that a lot of our patients are having molecular profiling because we have a lot of tailored therapies, right? And if you have say a FLT3 mutation or an IDH1 or IDH2 mutation, we have special oral drugs that we can use that are really effective. So a lot of people are getting this molecular profiling of their malignant cells from their bone marrow aspirate. But for a lot of these genes, we can't actually say that that mutation is only present in the malignant cells. Maybe it's inherited and in all the cells of their body. So remember that term germline means inherited, and somatic means it's only present in the cancer cells. So when somebody first presents, we get sort of a burden of how much mutation we see. And after treatment, if somebody goes into remission, then we can't see their cancer anymore. So all of those variants will disappear, but the inherited variants will always be there because they're in every cell of the body, not just the leukemia cells. So we use this plotting over time, if you will, of the percent of cells that have the variant as a way of finding these inherited mutations. So here's a patient of mine. He was 78 when he presented with acute myeloid leukemia. You can see that his family history is not that significant. His mother had breast cancer first at 52, so that's above our cutoff of 50 years old, and 2 uncles with lung cancer. And he only had 1 cancer. This was his leukemia. So he was not seen as high risk for having an inherited disorder. But we did that testing at diagnosis, that molecular profiling testing, and we could see a mutation in a gene called DNMT3A at about 36% of the cells and TP53 about 64%. But when he went into remission, that DNMT3A pretty much disappeared, but the TP53 remained really high. And that is what we're looking for over time. This person had an inherited DNA change in this gene, TP53, which is a particular syndrome called Li-Fraumeni syndrome, and we never would have predicted it from his personal and family history. We get it from looking at him over time with this molecular profiling. So when we do that molecular profiling for many of these genes, we cannot say whether it's inherited or whether it's only present in those malignant cells. For some genes, though, we can look at the exact DNA variants and we can predict that it's likely to be inherited or germline. And those 2 genes are CHEK2 and DDX41. DDX41 is the most common cause of inherited myeloid malignancy like MDS. And to date, almost all of the truncating mutations, that's a particular type of mutation, are inherited. So we can look at the exact result and pretty much know if somebody has an inherited mutation or not. Here's what this looks like when we plot it out. Here's that TP53, like that patient I just showed you. Now, most often TP53 changes are only in the cancer cells. So as somebody's in remission or not, these lines are sort of all over the map. But you can look closely and see these 2 people here who always have this variance at more or less the same level, about 50%. And those people have an inherited TP53 change, just like my other patient. and none of them would have fulfilled the criteria that we have defined for that Li-Fraumeni syndrome. So we think plotting this information over time is really important. You can see other genes like BRCA2, they're almost always inherited. They're not usually just in the cancer cells themselves. So when we see a deleterious variant in BRCA1 or 2 or other genes in that pathway, we really prioritize that patient for inherited testing. And we actually use this technique of plotting over time to discover a new predisposition syndrome, and that's in a gene called CSF3R. You can see what that plot looks like here. All these people here have that inherited change. And so these are patients who tested negative for what we knew of at that time. We brought them into the lab, did sequencing and discovery, and now this is a recognized clinical disorder. I just had an email last week from a genetic counselor in California saying she had found someone with an inherited CSF3R mutation. And so this is where this pipeline of clinical testing feeding the research and research feeding the clinical testing and then publishing it, and this benefits people across the country and across the world because everyone's paying attention to the literature and people are very aware of these new discoveries, and we hope that this is helping our patients. Now, some people say to me, well, why can't you just use that molecular profiling that you're doing on your MDS anyway? Just use that to do the inherited testing. And there are several reasons why that we call it somatic or the tumor profiling is not the same thing as proper germline testing. So I want to go through this logic with you because I think the more you understand, the more you empower yourselves, and you can be teaching your doctors. So in terms of those acquired DNA changes that occur in the MDS, we largely know what those genes are. We've defined them over the past 5 to 10 years. So that means the testing platform is pretty stable. But I just told you that we're discovering predisposition syndromes all the time. And that means the platform isn't stable. It's growing all the time. And so what we know of today is not what we know of next week. This is an ever increasing list on the inherited side. So we need platforms that are very nimble and can change over time. Secondly, these acquired changes in the malignant cells, they're in particular parts of the genes called exons. That makes it really easy to design a platform. But on the inherited side, we have a whole bunch of DNA changes that aren't in exons. And they're actually, a lot of the changes are inherited missing parts of chromosomes called deletions, which aren't covered by those other kind of platforms. And the kind of tissue that you use for the tumor testing is the affected blood and bone marrow. And that's exactly not the kind of tissue that we want for the inherited testing. The inherited testing requires, in the best case, that skin biopsy. And then finally, I already explained to you that some genes, we cannot look at the answer and know if it's just in the MDS or aplastic anemia, or if it's in every cell of the body. But these two genes, the CHEK2 and the DDX41, those are very special because we can look at the DNA change and have a very good idea whether it's inherited or not. In the last few minutes, I do want to talk about transplants. And this might be a little scary to some of you, but I think we need to have our eyes wide open. And we use stem cell donors all the time, right? To do these allogeneic stem cell transplants where we replace your DNA, place your bone marrow with somebody else's. And this is a true story. This is a patient that we had with leukemia, and molecular profiling was done on that leukemia. And two changes were seen in the DDX41 gene. The one I told you that we can look at the exact mutation and we know pretty much if it's inherited or not. And this D140 frame shift, it's a type of mutation. This one is really common as an inherited mutation. So I can look at this and remember that allele frequency is about 50%, like we were talking about. So I pretty much know that this one is inherited just by looking at it. And in the leukemia cells, it's also present about 10% of the time with this R525H change, and that's the hot spot, acquired mutation that happens in the context of an inherited mutation. So this is a combination that's sort of screaming at us that that D140 frameshift is inherited. And I presented this lecture to my transplant team. And as I was giving the lecture, one of the nurses raised her hands and she said, "Lucy, I think we have a patient with this DDX41. And this is the patient I'm sharing with you today." She was absolutely correct. We did proper germline testing and we confirmed that that D140 frameshift was inherited. This patient went on to an allogeneic stem cell transplant. Now, what would have happened if we had used a related donor without recognizing that this was inherited in the family? And we know, at least for inherited mutations in RUNX1 or CEBP alpha, is an absolute no-no to use stem cells that have these mutations in them, because these stem cells can't function without normal RUNX1 or normal CEBP alpha. And so donors who have these mutations, they don't mobilize their stem cells properly. When the stem cells have been used unknowingly, they have not engrafted well in the recipients. They don't function well. The donors come down with leukemia. They get leukemias in the donors. It's really terrible. It's devastating for the families. So we really need to think about this in advance of doing these transplants. So in this case, this person didn't have a relative who was appropriate. Person was in remission and had an unrelated donor transplant. And in this case, the donor cells engrafted really well. And the doctors wanted to be sure that this person was really in remission after transplant. And they did molecular profiling. But I told you this person was all donor. So when we did that molecular test, we were profiling the donor. And the donor had one of those CHEK2 mutations. So this is a problem, because now this person in the bone marrow has another risk in this other gene called CHEK2. And what this means is that we're really not paying enough attention to our donors, I think. And I think we need a lot of advocacy to start doing this kind of testing uniformly in our donors. There's a lot of resistance to this in the field because doctors want their patients to go to transplant. Transplant doctors have not been thinking about this, and we don't know what's the outcome, right? Are these cells going to be fine in this recipient, or are they going to go on to develop a donor-derived leukemia over time? Also, I would say there's a lot of ethics involved here, right? Because this person now knows molecular information about their donor, and I don't think that's right. So what I've been advocating for is, if you're going to do molecular profiling after transplants, confine the results to the positives that were in that person's leukemia, and don't tell us about other things that have to do with this unrelated donor. So there are a lot of issues. I would say I'm pushing the system a little bit to bring up these cases. And I think we all have to work together to make our treatments more effective. We have to do everything with our eyes wide open and really have a lot of discussion, information before we do these types of transplants on both ends, both for the patients and the donors. And with that, hopefully you have some questions for me, and I'm very happy to take them now.
Thank you so much, Dr. Godley, for the wonderful presentation. And we do have some questions. Our first question comes from a family member whose husband had MDS, and so did the husband's brother and sister. And they're wondering if they should have their children tested, and they are adult children, and how would they go about doing that? Or should they, like, what would be involved? Because there does seem to be a family predisposition to MDS.
Absolutely.
could it have been maybe, and they're wondering, or could it have been something environmental?
Yes.
And how would you know the difference?
Right. It's an excellent question. So families not only share their DNA, they share their living space. And so they're exposed to the same environmental insults. And I have a slide that I didn't put on this slide deck that is the mix of the inherited DNA with the environment. And I think all cancers are a little bit of both. And it's really hard to tease that apart. It's very hard to test for environmental exposure because we eat and drink and breathe all the time and all over the world. It's hard to quantitate what you've been exposed to. But your DNA is really easy to sequence. And so it's very easy to determine if there is inherited predisposition. So at least we can deal with that part of it. So for someone who had MDS, whose brother had MDS and sister had MDS, or any other kind of blood cancer, that person, you could see, according to our criteria, absolutely deserve testing for inherited predisposition. Now, if the husband in this case had a transplant, we certainly don't want to test the blood or the bone marrow, and we wouldn't anyway. I already told you that's sort of the worst tissue to use because it gives false negatives pretty frequently. So we would do a skin biopsy. And in this case, you would want to do the skin biopsy on one of the people who had MDS, because if there's something inherited, presumably that person has it. So in this case, the husband or the brother or the sister who had the MDS would have a skin biopsy, and that represents their inherited DNA. And we would find out if there's something that we know of today in the family. And if there is, then we can do cascade testing throughout the family. And that would include this person's children, other siblings, cousins, for example. And if anyone has passed away, often we can do this on a research basis from another sample that might still be in a pathology lab somewhere. So a colon biopsy, a skin biopsy, an appendectomy. A lot of those tissues are kept as wax blocks. They're called paraffin blocks. And we can take the DNA from those blocks and run this testing on a research basis. This is much better than starting with the children who have not had cancer yet, because there could be something in the family and the children just didn't inherit it. So the children will test negative, but the family still is positive. So it's always best to start with someone who had cancer. And hopefully that answers the question. Now, in terms of how to access this kind of testing, it's probably best to just contact me, and I can find out where you are in the country and help you figure out the best place to get the testing. Unfortunately, this kind of testing is not available equally throughout the country. So I can't give you a blanket answer of how to get it. It sort of depends on exactly where you are.
Thank you. Does it, for treatment options, does it matter if your MDS is hereditary or not? Does that preclude certain treatments that MDS patients consider or not consider?
Yeah, this is an excellent question. And generally speaking, for the treatment of the MDS or the aplastic anemia itself, initially, it does not affect the treatment. In fact, several of our inherited predisposition syndrome patients actually, I think, are more chemosensitive. I think they do better, sort of like BRCA1 and 2 mutation carriers. But I would say if allogeneic stem cell transplantation is going to be used to maintain remission, it's extremely important to think about these family situations and the donor and the choice of the donor. And so initially, in terms of initial chemotherapy, no, it does not affect it. That's why we have time to get the skin biopsy growing and do our testing. And then hopefully we have this information at the time of transplantation.
Thank you. This question comes from a parent whose 1-year-old has been diagnosed with MDS. And looking back in the family history, her father was diagnosed with AML. They have 2 other children. Should they look to have those children potentially tested, they may be potential donors in the future for the child with MDS.
Right. This is a very important question. And I would say the most important person to test first is either the 1-year-old or the father, someone who's had cancer, because then you'll know what is in the family. Is it SAMD9 or SAMD9L, like you would think just from the age? Could be GATA2. I mean, there's overlap, but most likely would probably be SAMD9 or D9L. And then that information can be used to choose the donor. Now, sometimes I have to say, the only donor we have has one of those mutations, not RUNX1 or CEBP alpha. I personally would not ever recommend using a donor with RUNX1 or CEBP alpha, but for some of these gene mutations, we don't know whether the presence of the mutation makes a difference or not. But at least we can talk with families and we can talk with donors. And if they want to accept the unknown risk, that's fine. So I would say, again, it's most important to test the person with the MDS or the blood cancer or the aplastic anemia, and then go from there within the family.
Thank you. Our next question is there any new research findings for MDS patients with TP53 abnormality?
Right. So for TP53, remember we talked about most of the time, that's only present in the malignant cells. Most of the time, it's not inherited. It only happened as an acquired event in the lifetime of that individual, but all their cells are normal. I did share with you a couple of cases where the TP53 variant is inherited. And so every cell of the body has the TP53 variant. Right now, the TP53 mutant MDS cases, whether they're inherited or not, they are generally more resistant to chemotherapy. And we're developing new approaches, new chemotherapies that will kill those cells. And there's very exciting research in that regard. There are several new drugs that look to be promising for TP53 mutant MDS, regardless of whether it's inherited or not.
Thank you very much for that. Are there certain centers that are doing more genetic testing, and should every MDS patient seek genetic counseling?
Yes, this is an excellent question. Yes, there are centers that are more familiar with this throughout the country. Should every MDS patient get inherited germline, inherited testing? Right now, any MDS patient diagnosed at the age of 40 or younger deserves inherited testing based on our work that shows 20% of them have an inherited mutation that can be identified. Will we eventually take away that age cutoff? Will we just do every patient? We should have that answer very soon. So we're doing another experiment, which we're doing in collaboration with the International Blood and Bone Marrow Transplant Registry. So we've taken every MDS patient and their related donor, and we've looked for these inherited mutations. And in this case, we know that the mutation is inherited because we're requiring that the person and their donor had the DNA change. So that has to be inherited, that 2 relatives have the same change. And we can see in our cohort of about 400 individuals, about 30 of them have inherited predisposition. That's almost 10%. What we don't know yet are the ages of those people. If all 30 of those individuals are younger than 40, then we have an age cutoff. But if they are distributed across the entire age range of life, then I think every patient with MDS deserves inherited testing. And I don't know the answer to the experiment yet. So stay tuned. This international foundation and others are very aware of this kind of research, and that's why we have these webinars to update our public about the latest in the research. And so right now, I would say the standard of care is MDS at the age of 40 or younger, but very soon that may change to be everyone.
Thank you. Dr. Godley, we have a question which is regarding the cost of the testing. Are you aware that there is difficulty sometimes with testing? And the question reads, I have MDS that went into remission, but later biopsy showed I had a different MDS from my donor, which was the sister. Insurance will not pay for testing unless she is displaying symptoms. Are you aware of, have you run into this with other patients?
I am extremely aware, and I fight very hard against the insurance companies to cover this. The problem is the insurance companies are behind the science, right? And that's to be expected. We don't think that insurance companies should be driving the science and the understanding. It's just that we need to help them get up to date pretty fast. And I do my best. I actually have a phone call later, or a webinar later this month with Blue Cross Blue Shield Genetic Counselors of California to update them. And I need all of you out in the lay public to put pressure on your insurance companies to get up to date. It's a very difficult situation because the insurance companies are not required to have policies for these kind of tests or any test. Without a policy, they consider the testing experimental. Once it's experimental, they don't have to cover it. So because there's no requirement for them to have a policy, they can hide behind that and not have a policy, or have a policy that's totally unreasonable. I had a conversation with a medical director of an insurance company last week for a 29-year-old with aplastic anemia. And from what I just shared with you, you would recognize that aplastic anemia diagnosed under the age of 40 deserves inherited predisposition testing. And from the feather diagram that I shared with you, you would understand that more than 10 genes are responsible for that potentially, right? We have to look in more than 10. And the insurance company would pay if my panel had only 10 genes or fewer, but not if there were more than 10. And I said to the medical director, how can you live with yourself honestly when you look up the latest review article on aplastic anemia and you can see that there are more than 10 genes? That's the biology. I mean, it's a completely ridiculous policy that you're going to limit the number of genes I can look at. You're going to require less than comprehensive testing. I mean, I'm pretty direct with people, as you can see. I wrote a very strong rebuttal letter, and I'm pleased to say that 3 days later, the insurance company approved the testing. It takes a lot of time to talk to the insurance companies. I'm doing my best as one person out here to do that and change things, but you also have to advocate. And I think, you know, the BRCA community had a lot of patient advocates for a long time to demand the testing. I think we need the same sort of thing in the blood cancers. And in this situation, what you're talking about absolutely deserves inherited predisposition testing. And again, in this situation, the easiest thing is just call me or email me, and I'll do what I can to get testing. The out-of-pocket testing at the University of Chicago costs about $500, which for a lot of people is too much money. And we hope that insurance companies will pay. For some people, $500 is a reasonable amount to pay. So that's how much our laboratory charges. I can't speak for other laboratories, but it's not tens of thousands of dollars. It's usually on the order of hundreds of dollars to get this sort of testing. But I do believe insurance should pay, and I'm doing my best to change the standard.
Thank you, Dr. Godley. And I'd like to add the Leukemia and Lymphoma Society just opened up a fund which does help patients of blood cancers with the cost of lab testing and things. So that may be a resource to help with the financial cost. And their phone number is 800-955-4572. And if the patient that asked this question, if you need that information again, please feel free to email, and I'm happy to provide that information again. Oh, Thanks, Dr. Godley, for sharing your time and your expertise with all of us today, especially with this wonderful information that's so important for patients and families. If you'd like to watch this webinar again at a later time, it will be available on our website within 2 to 3 business days. If you have any additional questions, you can send it to us at any time in 3 ways. Send an email to help@aamds.org. Call our helpline at 800-747-2820, extension 2, or submit a question on our Facebook page. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today and making us your resource of choice for information on bone marrow failure diseases. The AAMDS-IF Medical Advisory Board and team are always here to support you and your family, as we've done for the past 37 years. This concludes our program. Thank you, Dr. Godley, and have a great day.
Thanks, everybody. Take care.